There we go. All right. So hands up, who's ever had back pain? Okay, so actually the majority of you. All right, so I know Catherine has chatted a little bit about things like the stats. I think in America, the stat is over 80% of people in their lifetime will experience back pain at some stage. So it's very multifaceted and complicated back pain, especially just generalized lower back pain. So we look at causes. It can be anything from muscular imbalances, skeletal irregularities, one leg higher than the other, degenerative bone kind of diseases, osteoporosis, fractures in the vertebrae, bad posture. It can be congenital. You can just be born. There's things like spinal bifida when there isn't complete formation of the spine. Things like trauma, injury. There's a whole range of things, and it is complicated. But the way to work with back pain, when I was in the States doing that course, Alison West always used to say, take the whole person as a whole and put them in the whole. So basically looking at this person that's got back pain, we don't just kind of look at the area and say, well, where's your back sore? Or we say, well, what do you do for a living? What's your profession? What sports do you do? How strong are you? What is your age? Things like even emotional, where someone is emotionally. And it sounds strange, but if you think about someone who's really depressed, or someone who's something's going on, how does a depressed person look? Their shoulders are rounded, their chin is down. This is the kind of posture, and this starts translating into things. Soldiers, they find. Soldiers have a certain posture, very upright. They started to develop barrel chests because that's the way they have to stand. They have to stand upright, these barrel chests with very flat necks, and the chin pulled in, standing upright. So what you do, that all starts to contribute. So I would look at a person saying, okay, tell me all of these things. Now let's look at each individual little piece of what's going on. Stuart McGill, he is amazing. Dr. Stuart, Professor Stuart McGill, he does a lot of spine research. He's worked in laboratories and clinics. He's one of those that get in there with bodies. He's worked with, it's fascinating. They called on Stuart McGill for a murder case, actually. He works with huge athletes. He gets asked to consult on sort of the biomechanics of the spine. And he was called in once to go through an autopsy, to have a look at, because there was nothing else, there was no other DNA except skeletal, so pelvis and spine. And he's actually hands-on. And he said it's fascinating. He worked with a forensic anthropologist, and they got chatting, and he interviewed her, and they say that we've spoken a lot about this in this course. I know Catherine has, I have a bit as well, about how different we all are, the variance in bodies. And they found that Polish people in Poland, Polish nation, have got the highest percentage of hip dysplasia. So because when they had a look at the pelvis and the hips and the etc., they found that their hip, the sockets, was the shallowest. So hip dysplasia was something that happens a lot in Polish people. On the other side, the Celtics, so that's Ireland, Scotland, Isle of Man, Brittany, those areas, have the tightest and smallest ball and socket. So it actually, my Demi has been modeled on an actual body. So Stuart McGill's has been modeled around an Indian person. So he's got an Indian spine. So different nations have different bodies. So that's another thing to take into account. It really is, it's fascinating. So Dr. Stuart McGill, when he sets up an appointment where someone comes to him with back pain, he sets an appointment of 3 hours long for every single client. Can you imagine? So that's how complicated it is, because he takes that person and puts them in a hole and goes through everything. has a look at all what's going on with them. And he says sometimes it takes him 10 minutes, sometimes it takes him 3 hours. But what he does is looks at the person, he identifies the movement, the posture, and the load. Those things that could be causing pain. And then he eliminates them and then replaces with different movement, posture, and load. So that's kind of, in a way, how I would work a little bit with Backcare. Having a look at, and I'm not diagnostic, so that's the one thing. But just, if I see someone, I say, right, I want a doctor's report, especially if it's something like a herniation or a scoliosis. If someone comes in with general back pain, we work on it, and I'll show you a few things that we can do, because that's general back pain, and someone who is coming to your yoga class is not in such excruciating pain that I would assume that it would be a herniated disc that's just happened, although I qualify that because we'll chat about that. A herniated disc can be quite tricky. But in general back pain, there are certain ways to work with it that we can, I don't want to talk myself into a circle here because we don't want to be diagnostic. But if someone comes to me with back pain, I want a doctor's report to say that they're okay to do yoga. And it's better for me to have the actual report in terms of scoliosis, to see the curves, to see what's going on, if someone's got a herniation, exactly where it is and what kind of a herniation it is. So very specific, we need to drill down and eliminate a whole lot of other conditions. So I would also I've just made a little note here to log on to Paul Grilley, Paul, and then it's GRILLEY.com. Just really interesting. He's got a website that includes a gallery of bones, femurs, pelvis, the real live bones. So it's just incredible to see the differences, different pelvises, etc. So he's got a whole, Paul Grilley is the man that came up and he developed a lot of yin yoga. So he's known for yin yoga, but he really studies anatomy as well. All right, so we know that with the back, like any other tissues in the body, they need to be stressed. So a healthy tissue needs stress. So if someone comes to me with a bit of back pain, the last thing I want to do is have them lie on a couch for weeks and weeks. We know that this is not the right thing to do with any kind of injury, really. Someone comes with a sore shoulder, the last thing you want to do, my mom fell out of the bath and hurt her shoulder and was told to put it in a sling. She kept it in a sling and it's turned into frozen shoulder. So gentle movements, that's what we're looking for. Tissues need to be stressed, and it's important to try and find the Goldilocks. Bernie Clark talks about the Goldilocks philosophy. Where's the tipping point? Not too much, not too little, just the right amount, but it does need to be stressed. So we do need to move them. Stuart McGill also prizes for the spine, which is interesting, stability rather than mobility for the spine and the sacrum. And he talks quite a lot, and you can look a little bit more deeply if you're interested into it, about the stabilizing. He calls it stiffening around the spine. And I know you've had a lot talk about the core. What is the core? So for me, I think Stuart and Bernie, which I follow quite, I follow them, is the trunk. I talk about the trunk, the pelvic floor, the diaphragm, the muscles and that surround the spine. For me, that is my definition of the core. So he talks about the stiffening of the core. So he calls it stiffening of proximal stability for distal mobility. So kind of a bracing, a control, like your powerhouse from the core to be able to push and to move. So he talks quite a lot about that, which I find quite interesting. There's a process where Bernie Clark, when he's doing, for instance, Bernie's a very big yin, he's the top guy in yin. He, when works with the spine, talks about spacing and bracing. So if there is someone who has a little bit of back pain, or if I'm working the back sequence, I often apply this. So what we do is we take the fingers, the bottom rib, and the little finger at the top of the hip. And then you almost open up the fingers. So you can imagine opening that space. So this is your spacing. So imagining that feeling. And then the bracing is to exhale. So you inhale and open up the fingers. And then on the exhale, push the fingers outwards. So the belly is not popping out. You're not breathing out. You're breathing to the sides on the exhale. And you can kind of feel that everything tightens up. There's this stiffness. So that is the bracing and the spacing. And he uses that a lot. Uses that in a forward fold to do the spacing and bracing. In a Vashisthasana side plank, he will say, use your bracing and spacing. So you get that kind of, as though someone's about to punch you in the stomach and then rolling to the side. So that's bracing and spacing that he uses. We talk about elastic equilibrium. So for me, that is, for instance, that if you had to go and lie in the Dead Sea and you just had to float, that elastic equilibrium is that absolute, that space where you just kind of held. Your muscles are not in tension at all. They're just it's the skeleton holding you. So this is the position where the spine is in its natural, we spoke a little bit about this, natural curves. So when they need to be stressed, but it's the Goldilocks philosophy. If we start to, and in this elastic equilibrium, the natural curves of the spine are that way for very specific reasons. We spoke a bit about that as well, making the spine strong when they've got those curves, allowing movement, allowing balance. So that lordotic curve and the kyphotic curve, they're all balancing each other out. The center of gravity is set to a certain point. So when we start to mess with that kind of, and I think it was Claire, I don't know if Claire is here today. Claire was asking about, yes, there she is, that posterior tilt all the time. I think it was you, Claire, yes. So what you're doing is your elastic equilibrium, and there's no pain, but then you're starting for some reason to posterior tilt all the time. So you're, in a way, you are messing with that elastic equilibrium. You're taking that natural curve out of your back. And do that long enough. Stressing the spine in that way will start to cause problems. I can understand if you're tucking your tail, because you're in pain, you've got too much of a lordotic curve. You know, we said that hyperlordosis. Start to think about posterior tilting slightly to get out of that pattern would make sense, but not for no other reason. If there's no pain and you're in your natural curves, you're in elastic equilibrium, you don't want to start changing that, because all those vertebrae and all the little nerves are in very specific places for reasons, and you will start to mess with that structure. I'm sorry, Kara, I hope Kara is going to watch the video, because Kara asked about forward folding. Remember, she had said, what's this thing about standing forward folds, seated forward folds, and the discs, etc.? What is the deal around that? So that will lead us into a little bit more of herniation and looking at forward folds and the back. I wanted to talk a little bit about the discs first. As we know, we've got 23 of them in between the vertebrae, so I'm not going to go through it too much. We have been through it. All these little spongy bits. There's 23 of them. They make up 25% of the length of the spine. They're there for stabilizing the spine, for giving us movement. So because they're there, we can bend and side bend, etc. And they also space the vertebra. We don't want the vertebrae sitting on each other, on top of each other. We want something in between, like a little bit of, it's a shock absorber. So the structure of them, they're made out of an annulus fibrosus on the outside, which is a ring of concentric sheets of collagen. They're round in circles, and they're quite tough. They form the circle on the outside. And then on the inside, you've got a nucleus pulposus. So picture your jam donut. That's the real common kind of explanation of a disc. You've got the dough, or the, what's it, spongy bit on the outside, and you've got the jam on the inside. The nucleus is made out of water collagen, type 2 collagen, and things called proteoglycans. You've got your vertebra, both vertebrae sit. So if we look at this one, this vertebra has got an intervertebral disc at the top and the bottom. In between the disc and the vertebra is something called an end plate. So you've got one end plate at the bottom, the superior part of the vertebra, and one end plate in the superior part of the vertebra. And what those end plates do, the disc is avascular, so it doesn't have its own blood supply system. Those end plates receive the nutrients through by diffusion into the intervertebral disc. So that structure of the disc, just before I forget, we don't have one between the skull and C1 and C1 and C2, and we also don't have any of those discs in the sacrum and the coccyx. Okay, so we don't have to worry about any herniated discs or anything there. Herniation of a disc happens 15 times more in the lumbar spine, and we know why. There's compression, and there's more mechanical force there. It's more kind of, you know, if you picture a lever, and if something is fixed, and you've got, actually there's something in a book I read saying, imagine a pair of pliers, so at the base of the spine, and if you put your finger in those the jaws of the pliers, and then imagine the handles to be as long as the spine, and if someone has to pull the handles together and bend it, most of your mechanical force and that is going to happen right at the base. Okay, so only 8% of cervical herniation, 1% in the thoracic. Remember, we said we've got the rib cage there, we've got those attachments, and it's quite stable. So very, very seldom are you going to get a herniated disc there. Okay, the herniation here is, and if you can see this, there's your disc. So that's your annulus fibrosus on the outside with a little nucleus on the inside. There is a picture here of a bulging disc. So we get differences. We often talk about a bulging disc, a herniated disc, a ruptured disc, a prolapsed, a slip disc. Slip disc is a misnomer. It just does not slip. So it's either bulging, so it's just various degrees. So you've got your jam donut, or think of like a balloon sandwich. If you had to push and onto the one side, you squeeze a little harder, what's going to happen to that balloon? It bulges, there's a little bulge. Yeah, exactly. So what's happening is that nucleus is starting to push through into the annulus fibrosus, and that's bulging. So nothing's broken through anything, but there's a bulge. Now this can be completely asymptomatic. You don't even know. And a lot of the time, people will go for an x-ray for scoliosis or a hip x-ray, and the doctor will say, oh, you've got a bulging disc at XYZ. What? And people get quite upset, you know, it sounds really, a lot of us have actually got a bulging disc without knowing. It can often happen. And it can often right itself. Within 4 to 6 weeks, it just kind of gets absorbed back, and especially if you're doing the right things. You know, some of the things I'm going to show you to do, if you do those in yoga, it kind of absorbs itself back. So it can be a bulging disc, or it can be a herniated disc. So the herniated or prolapsed or ruptured disc is where that nucleus actually breaks through the annulus fibrosus. So that's when you're going to get that little red spot. You can see it's actually poked through. So usually the action for a herniated disc is a forward fold, a forward bend. So what happens to your vertebra when you fold forward? In the front, they approximate, they come together. So picture your spine, the front of the spine, the vertebrae come together, and the back distract, they open. Okay, so you've got all this pressure in the front. So that's your balloon sandwich at the front. That nucleus is going to start to bulge towards the back. okay? So if it's going to pop out, what it's going to come across are the spinous processes. Or we've also got that posterior ligament, remember, that runs all the way down the back. We've got the anterior ligament that comes down the front. Now the anterior ligament is tougher than the posterior. So it's not, usually that's one of the reasons why the nucleus won't poke to the front, because it's got a tough ligament to hold it. It's going to poke towards the back on the forward bend, but it comes up against the spinous process, the posterior ligament. So what's it going to do? It's going to poke towards the side. And what's at the side? These little yellow guys. These are the nerves. So that's, if it then, so it's called a posterior lateral herniation, to the back and to the side. So that, and when it touches that nerve, that's when you get that pain. That's the sharp pain, but it might miss the nerve. And if it misses that nerve, well, you might be completely asymptomatic. So it will either bring you to your knees with pain, or you won't even know. So that's interesting. So what's happened is you've had that compression, and the other thing added often is a twist to that. So that's your classic herniated disc. You lean down to get something, you forward fold, and you twist. Because a twist comes with its own compression, and it also stretches the wall of the disc. So there's two more things added to that. So that can happen in a forward twist. So we're designed to be resilient. The spine, there's a predisposition. You could be predisposed to a herniated disc. There might be wear and tear. There might be, other factors that are contributing to it, but we mustn't think now that, I'm going to talk about the forward bends and that in yoga, that we should be staying away from forward bends, or that they're dangerous, and we've spoken quite a bit about this, I think Catherine have as well, that forward bending, we're supposed to forward bend, we're supposed to round the spine, that's the way we designed, it's all good, except if there's something going on and there's this wear and tear, and slowly but surely. So what we're going to talk about are the different types of forward bends that we might have to be careful. Well, no, I'm not going to say be careful of. I'm going to say the ones that put the most pressure on the discs. So it doesn't have to be a problem. If we look at forward folds, standing forward folds. So we know that the primer movers are the abdominals, especially in the seat, in seated. Standing, but the resistors are the erector spinae and the multifidus, right? We spoke about those muscles. They're the ones that are resisting a forward fold. So the erector spinae are important to think of. When we're in a standing fold and we fold over, if the sacrum is able to tilt forward enough, it'll allow the spine to hang, basically. So, and the erector spinae are not, they're slightly engaged, but not really. You're hanging all the way down. So you're getting a little bit of gravity pulling the spine down and the vertebra opening up. So this is good. We know that this is not going to, shouldn't do anything injure the discs. So the erector spinae are moderately turned on. In a supine forward fold, think about lying on your back, Paschimottanasana, like a Supta Paschimottanasana. Gravity is not working on the vertebra at all. Okay, and the erector spinae are completely turned off. They're not working. You're lying down. So that's not going to be working on the discs. Then we get to the seated folds. Now you can imagine, especially if the hamstrings are tight, you can imagine what's happening there. You've got gravity, first of all, that's working on it, on the discs. Okay, the pelvis is fixed. So when you're leaning forward, there's quite a lot of mechanical force there because the pelvis is not able to move in the direction, it's fixed. Then you've got tight hamstrings. They are pulling on the sit bones, what is the ischial tuberosities, that's it. They pull on that to round the spine, posterior tilt, because they're pulling on the pelvis. So then you've got that posterior tilt. And then you've got the erector spinae. Remember, those are the extensors that take the back backwards or back to neutral after flexion. and they're turning on, they're contracting and pulling the vertebra closer together. So now you've got gravity, you've got a lever and load, you've got the posterior tilt, so the anterior closing of the vertebra. And now this is what's going to be putting quite a lot of pressure on the vertebra, on the discs. So again, I'm not saying that it's a problem. It can be, but it's the one out of all the forward folds that is going to put the most pressure on the discs. So anyone got any questions? Does that make sense? Okay. So for that kind of forward fold, yeah, Eva.
Yes. I just like, so it would also mean now with the twists that like binding and twists could also cause a problem, because most people have to flex their spine when they twist and bind, because they just don't have that much motion available otherwise. So they use the flexion of the spine to get into the deep position of the twist. And then you would have the leverage, the outside leverage as well with the bind. So that would make the load on the discs even
more. Exactly. More. Exactly that. And yes, twist with binds, because what also happens there is people are using the leverage and the wrenching of it. So they really are, you know, there's an extra force with a bind. As I said, I think last week, you know, sitting with a twist, if I want less of a twist, it's that organic. So instead of taking, if you can see my knee, instead of using the knee that way, you might just want to rest it. That's more of an organic twist. So that binding is definitely putting more pressure on a disc, you're right. Yeah, absolutely. And something that I generally do in a class anyway is always lengthen the spine. So I'm going to show you a whole lot of traction. Easy, simple, quick things. Traction first before twisting. It just makes sense. You know, if someone's been sitting all day, slumping down, and the discs have got a little bit, and now you twist, you can imagine that that's, you know, there's more opportunity for the vertebra to be kind of, especially if the discs are thin for some reason. So rather get length and then twist. So that is, yes, Eva.
The second question is, would that also include side bends in a certain way? If you do really, because if you, the same thing, if you bind in the side bends, most people will need to also slightly rotate and flex their spine. And as it is the posteriorly laterally motion that is the disc is going, it might also then apply to side bend with certain body proportions, especially if you don't have the range of motion to get your hand to where you would bind, or even if you just use the rotation and the flexion of the spine to get into the side bend further, because side bend is restricted.
Yeah, so you're saying, is the side bend and sort of a weakness or an opportunity for a herniated disc?
No, I would say it might be a problem. It might be a posture that could cause problems, and if you bind and if you like, if you have a bulged disc, that might cause herniation.
Yes. So yes. So a disc, so it has the like we said, is more what's the word? Is more gone completely blank.
Prone.
It's easier, more prone, yeah, to herniate to the side laterally or to the back, because there is that is the distraction of the vertebra on the side in a lateral bend. So as you say, with the binds, is yeah. I don't think I'm answering that question very well.
No, but you said it might be, so that would be something when you have a client that has disc problems.
It's definitely to be avoided. Absolutely. Yeah. So if I had someone with a bulging disc or any problem with the disc, I would avoid lateral flexion completely, especially to start with. So
that answers my question.
Yeah. So basically what I want to do is when I'm working with someone with a herniated disc is to keep the spine neutral and no lateral flexion. So what I'll do is in the practical is show you how I would, you know, the point is when I'm working with someone with a herniated disc or general lower back pain, I want them to carry on with their yoga. So when they come to me, I want to give them Trikonasana to do, but I have to modify it. So you'll see with Trikonasana, sometimes we get into that lateral flexion. There is a side bend. I don't want them to do that. So I'm going to make sure that when they're in their Trikonasana that they keep they keep length and they keep the side body straight. That's number one rule actually, Eva, for herniated disc. No side flexion because it could be that lateral
that's
area.
What I was thinking as well. Okay.
Exactly. Yeah. Okay, so we were talking about those forward bends. So if I wanted to make sure that, and even in a general Backcare, yoga class, if I was going to do Kurmasana, a seated forward fold, I might follow these steps anyway, even if someone hasn't got disc problems. So what I would do firstly is often the hamstrings are related to forward folds, right? So people have, and we've just spoken about this, that pulling in the lower back, etc. I would want to make sure that I release those hamstrings, everybody's hamstrings. And I would do it firstly in a way that is completely kind of easy and safe for everyone. So I'd probably do a supine. I'd probably do Supta Padangusthasana. I'd start my class with everybody, so there's no gravity involved, etc. Erector spinae off. So Supta Padangusthasana with a strap, loosen up the hamstrings. So make sure that the hamstrings are released in safe ways first. Then I would think about the traction. Remember we spoke about getting a little bit more length first. Easy, get them to sit in Dandasana, put your hands on the floor and lift slightly. I mean, that is actually, you could all come into a little bit of traction by putting your hands on your chair, keeping the arms straight and just lifting the sit bone slightly off and allowing that pelvis to be heavy, that heaviness. And suddenly you feel sort of a little bit of a lengthening. So some kind of traction. And later on this afternoon, I'm going to give you another traction one. So releasing the hamstrings, getting a little bit of traction, and then I would, so if someone is sitting in Dandasana, try and make sure that they're at a 90 degrees with the pelvis to the legs. So that might mean lifting the sit bone, sitting on a little bit of a blanket, something just to get a little bit of an anterior tilt, and then folding from the hips. So hinging from the hips first, lengthening the spine, getting that length, and then when they're there, then they can start to run. So remember we said this is not someone with a herniated disc, etc. I'm just giving a class for forward bends. That's fine. But get the length first, get the traction first, hinge as much as you can at the pelvis. Then when you feel you can't hinge anymore, then round from there. Okay. Just see that I haven't forgotten anything there. I wanted to mention something else there. I know. Just see. And also the last thing there would be to release the hip rotators. So that would be things like, so there we've got those five, I think it's 5 muscles, the obturatus, the internus, externus, then you've got the gemellus inferior, superior, and the piriformis. So that's one that we stretch quite a lot when we come into these forward folds. And the quadratus femoris, I remember them. There's actually an acronym which I can't remember. And those poses would be things like pigeon pose, supine pigeon, standing pigeon, figure fours, your folded pigeons, etc. So that's a little bit of a process that I would do. Traction, release the hamstrings, get your traction easily, then do your 90-degree pelvis to the legs and release the hip rotators. Okay. Any questions on that? Yes, Emma.
Hi.
Hi, sorry I missed the first half
No
an
problem.
hour.
Welcome.
Thanks. Just on that, so I'm a physiotherapist,
Yes.
and this is the type of patient I see quite often.
Yeah.
So I really like what you're saying. I agree with you.
Good.
But yeah, what did I want to say? Oh, when you were talking, you and Ava were just talking about twists. That's when I hopped on, so I might have missed something. But that you won't do twists with when there's a herniated disc. So
I'm going to qualify that before you carry on.
Okay.
I would do twists with a herniated disc, very mild twist, but not lateral flexion. Sorry, that's what
Lateral
I'm referring to.
Sorry. Okay.
Yeah.
Okay. So lateral. So the best chance of a disc herniating would be forward flexion and rotation, because that's what it does. It will herniate to the back or to the side.
Mm-hmm.
So I would not, unless you're working very closely with like your physio. You could actually do lateral flexion, because a lot of the time, but it might be to one side, because it depends on how it herniated. You could actually move it back, and that's a specific technique. But if you're working closely with the healthcare provider, you could actually help move it back into place. It all depends. I mean, these things are so intricate, so this is just my little baby 2 cents.
Yeah.
But you could, but never if it's not with your healthcare provider, I guess.
Absolutely.
That's what
I agree with you. Yeah, so that's what I was saying from the beginning. It's quite it's very intricate. I wouldn't do it unless I knew. And that's the thing, when I work with someone with a herniated disc, I need to see the report, because which side is it on and where is it? And often people will come to I don't know, herniated disc. Well, then I can't really work with you, because if it is to the side, we really need to be careful of that lateral flexion. And I agree with you, very specific techniques, which we'll do. And I'm not saying go out and just, use them, but this is what I would do with them, is to make sure that I'm not side bending, because it might be that you need to do, I don't want to say the exact opposite. So in saying that it can absorb itself, I think you might have missed that. We were talking a little bit about that there are certain actions that a physio can do, or that you could do on your own with yoga, that actually open up. So my technique is to work with opening up the anterior slightly, because that was the compression that's caused it, and then to doing certain things to try and absorb it. But in saying that, what you're saying with working with someone, I think it's very important, and that's something I've really found with the Backcare as well, that it's certainly not a one size fits all. It's actually crazy. I will give one person with a herniated disc an exercise that'll flare up something in someone else, and it's exactly the same thing, and they've got the same herniation. Get someone to lie prone with a rolled blanket up in their tummy to give a little bit of a curve can cause pain for somebody else. So it really is a kind of work and see. People are they're just structurally, there's so much variance in everyone, and we need to just accommodate that. We need to have a whole lot of tools in our pocket to be able to. I mean, I was in a class in New York where, we had to go to literally 5 herniation classes a day on that course. We had to do them, we had to assist in them, we had to watch them. And the one day a man walked in, pale and sweaty and shaky, and kind of, I've also worked with people with herniated disc where they have to stand against the wall, and they have to slide down the wall, and they have to get their shoe off that way. It can be that bad. And this man walked in for his herniation class, and I thought, are you kidding? Why did he even come to yoga today? But what they did was they took 5 bolsters at the bottom, laid them up. I mean, these studios have props beyond. It's just like tons of props. 5 bolsters, 4 bolsters, 3 bolsters, 2, 1. Had him come over, hang over the bolsters, so over his little pyramid, for 1 hour and 15 minutes. The classes are 1 hour and 15. He did not move except stay in that little pyramid hanging over. Now, for me, that shape didn't really make sense. That man stood up and he got out of that class with his shoulders back, his chin up, color in his face. Perfect. That's exactly what he needed for 1 hour and 15 minutes. Incredible. Now that might have been the exact opposite to somebody else. So it's really, it's quite a fine, tricky one to have to work with. Thanks, Emma. And let's see, same side would be my thought. It's balding out to the left. Can't arms too short. So let me see the beginning of that. Can't arms too short. Need to use blocks for that. That would be side bending to the opposite side there. What were you asking there, Eva?
The one with the arms too short is I can't traction my spine while sitting in Dandasana because
yeah,
I need to use blocks for that. And the one thing I just wanted to know, you will bend or side bend to the side where the disc is coming out, so to the opposite side that you are avoiding, to just bring it back to the middle.
Yes.
So you would put pressure on there deliberately to
in theory, that would work.
Yeah. Mm-hmm.
In theory, that would work. That might irritate somebody else's disc, but yes,
and I would never do that without like Emma.
Yeah, okay.
But, yeah.
And just on that torso thing, your torso is too long. That's interesting. So you would have to put blocks under your hands, right? That would help if you had blocks.
Yeah.
Lift up. Yeah. Yes. So Eva, I mean, I know that one of the techniques that physios use it quite a lot. I see Taryn, I'm coming. Is like a Sphinx pose. You know, so lifting up that way, so closing that back to reabsorb. But that I've tried that with someone where they don't like it. But that's a common one, almost like a little bit of a push-up, up and down. Yeah. Let me just see. Taryn, yes?
I just wanted to quickly ask, because I have a student who had an accident a few years ago, and she hurt her lower discs, and she basically has said that she has no padding left between her vertebrae, and but she's been recommended from her doctor and physio to go to yoga and to strengthen the muscles. So I was just wondering, like, what would you recommend would be your first thing to kind of take into account, and like how you kind of assess what she can and can't do? Just because, I mean, she seems to like work through things fine, but she kind of needs to like, I mean, I wouldn't want to throw her into a lateral stretch that then, you know, makes something.
So firstly, I'd want to see her doctor's letter, firstly, if she was going to come to class. And then the way I would start with that, strengthening, I would agree. I would start with so when I work with herniated disc, everything is very mild traction, very mild twisting, very mild strengthening. So I would start, so if I had her in a class, I would do a private class with her and start with very gentle traction. So maybe that means literally sitting up on a chair. So if she's lost that padding, you can imagine that the vertebrae are now closer together. So the more you lose that padding, the more chance there is that you start getting degeneration of discs, so the rubbing of the disc, because that little cushion is the one that separates. So she's lost that cushioning. So what you want to do is start just giving a little bit of space there. That would provide relief for her. And again, this afternoon, I'm going to give you some really easy tips for lengthening. And I think I said it last time, when in doubt, I tend to traction, mild traction, lengthen. It works for scoliosis, it works for general back pain, it works for discs. So very mild traction, and then start with the strengthening poses, like all fours. They call it bird dog. So you're on all fours, you extend one arm and one leg, activating front body very slowly. And I would start very slowly as well. Get her on all fours, extend the leg back, get the toes to the wall first. Lift the foot up the wall, keep the wall there. And then slowly, as she gets a little bit stronger, take the foot away. So those kind of strengthening exercises. I would probably, I would start there. I would start with mild traction, mild strengthening, and then also just very slow. You know, you can, in my mind, you can do all kinds of yoga movement, spinal movements, flexion, extension, twisting. I would do mild twisting again. So just oxygenating tissues. That's the point. When there's a problem there, I always feel we need to get blood flow there. We need to get tissues stretched, tissues oxygenated. So movements. I would go through the range of movements, but very gently. Emma, would you say that is a good strategy?
Yeah, I must be honest, I didn't listen to Taryn how old she was and how long ago she was. So I missed that first part, but I think if it has been a while, like I agree with you, you need to oxygenate it, but also if it's been a while, people tend to come to a class and they bring all their injuries, their old injuries with, and they think that, you know, like, oh, I had a disc injury a year ago, I'm going to damage it again. Not likely, you know. Yes, you might have stiffened into other places, but you're not going to go bam and injure that part again.
Yeah.
Like, I think people are too scared to move, you know.
Yeah.
Yeah.
I think if someone comes and they did have a herniated, and people are terrified to get a diagnosis of a bulging disc, or, you know, that hands in the air, they really are. And like I said in the beginning, Emily, you might have missed it, that it happens to a lot of us with an asymptomatic, and it can right itself. So even if someone has had a herniated or a bulging disc a year ago, I would still be cognizant of that. I'm not going to say to them, well, you know, you can't do this and you can't do that, but there are certain slight modifications that I would give with that, because as you know, if you've got that balloon sandwich, and you know what happens when you squeeze a balloon and it gets a bulge, when it comes back, it's slightly like it wrinkles a little bit, gets a little bit thinner. So just to bear that in mind, you know, when I work with herniated discs, or you might get someone in your class that says, I had a herniated disc a year ago, I would maybe offer a few little tips for them and say, if you're feeling anything, it might get a little bit inflamed or something, make sure, so one of the number one rules working with that is neutral spine with a herniated disc, working natural curves. So when bending or forward folding, rather than spinal flexion, rolling through the spine, do pelvic flexion. So hinge from the hips. So that's keeping you in those natural curves. Getting up and coming down. So if someone's got a little bit of a flare up, and I teach this way of getting up and down from the floor. What happens when you come down to the floor? And we'll have a look. We're usually rounding the back at some stage. So there's a certain way of getting down to the floor, which I teach all my clients. I teach older people, you know, heaven forbid, fall and break a hip and not be able to get up off the floor. I think everyone should be getting down and up from the floor a certain way, and I'll show you how to do that. So those little, I mean, with your lady with the disc, Taryn, I might show her how to get up and down from the floor in that way. Not to say, we don't want people to get the feeling that they're fragile or they're injured or anything, but just, you know, something to hold them in good stead. Yeah, Taryn, does that answer your question? I mean, with where to start?
Yes, yeah, thank you. I think it's just funny because when you kind of research it and you go into it and see, you know, what's out there to kind of get a bit of a guidance, it's a lot of just absolutely do not forward fold. So in anything that you're doing, don't forward fold and that kind of thing. And you can't really do a class without allowing your spine to flex at all, because as you're moving, it's a natural kind of curve. So yeah, I just found that interesting and I wanted to ask and just get clarity on that. But yeah, thank you.
So that traction, I think, is important because of what we spoke about, all the different forward folds and how it affects the, you know, and then the traction, the releasing of it, and then that pelvic flexion, I think, is important. There is a way to get around flexing your spine quite a lot in yoga, you know, and we're going to practice the Surya Namaskar when we do that as well. You know, there's tricks to do it, using chairs and that. So it's very difficult to do it in a public class if she's coming to public classes of yours, but if you're working privates, There's quite a few things you can do, and you'll be able to take away quite a lot from the session this afternoon. You'll be able to use a lot of that.
Thank you.
Let's see. Would you do ragdoll or too much traction? So that's coming from Lauren. Would you do ragdoll or too much traction with gravity? Is that for the lady whose back was sore, Lauren? Who's got this disc?
So I actually had a lady that had a herniated disc, but she could obviously only feel it in back bends, and
Okay.
she loved forward folds.
Yeah.
And she actually loved ragdoll, but she's also very flexible. So for her ragdoll with slightly bent knees, her stomach's almost resting on her thighs very slightly. Like obviously I wouldn't do it with someone that's very tight in their hamstrings.
Yes.
But now I'm just thinking, would that be too much traction or
No.
is that good?
No, I wouldn't say that, and especially because she loves it.
Okay, cool. Yeah.
I think that's a huge thing in yoga in general, that, you know, if someone kept telling me every time I fall forward it's really sore, well then I'd have to look at that. We'd have to say, well, you know, then I think you need to pelvic hinge rather than spinal flex when you come down into ragdoll, or come halfway with blocks, spinal.
Yeah. Okay, cool.
Yeah.
Thank you.
And then Eva says, educate the student about exactly what Emma said will help take away the fear. Yes, completely agree. There's, especially, you know, someone's got a diagnosis of something like degeneration of the discs. I remember my mom came home with her x-ray and she was devastated. 3 of her discs are degenerated, and one in, I said, okay. I think from the age of, and I can't remember exactly, but from the age of about 30, we all start with degeneration of the disc. You don't have to be 60. It starts quite soon, quite young, unfortunately. It's just wear and tear of the disc. It doesn't have to be a problem. You know, we keep saying these things don't have to be a problem unless there's pain. And coming home with a diagnosis like that, it does invoke fear. I completely agree with you, Eva. And then, you know, you've got to be able to say to the person, that's okay. I mean, I said to my mom, that's fine. Let's work on strengthening around the spine, strengthen the muscles. It's fine. I said to her, I've still got degenerated discs. Don't worry about it. So the fear factor, people start sort of not wanting to move to self-brace. There's a big thing on in back pain of bracing, that spasming type of feeling. You know, so we need to decompress and release those muscles around there. So pain is definitely going to make things worse. Yeah. Pain is an output of the brain of perceived danger, yes. And that perceived danger, you can see people who walk with back pain who have that kind of fear. You've seen people sort of shuffling around and not moving too much. It's trying to protect that area. So, yeah, exactly. Most is happening lumbar spine ragdoll with loads of knee flexion and not lumbar flexion, maybe. Spine ragdoll. Yeah, Emma, we've sort of spoken about when it generally happens, you know, when you treat a person. Yeah, I like that, Emma. In physio, we never treat an MRI or an X-ray, we treat the person. So that's what I started off by saying. Take the whole person, put them in the whole of what's going on. It happened a few years ago, she's gotten worse. In 13, a car accident, so there's a lot of fear involved. Yeah. Okay. All right, guys. 1 hour down already. Okay, is there anything, Sandra? Sandra? Yes.
Yeah. I just wanted to ask if you offer public Backcare classes, and if so, if you ask everybody what injuries, etc. they have.
So up to now, I have not done general Backcare public classes. So I've worked one-on-ones. The most I've worked with are herniated discs. That's the most common I get, and scoliosis. Those two. And a bit of hyperkyphosis. You know, well, let me qualify hyperkyphosis, which we might get time to talk about. Hyperkyphosis, rounding of the shoulder, over-exaggeration of the thoracic spine. That's hyperkyphosis, where the curve needs to be more than 45 degrees. That's just a very general average. So we've got 33 degrees curve in the thoracic normally. So if it's over 45, we start talking about hyperkyphosis. But not everybody with rounded shoulders and a little bit of a curve in the back has got hyperkyphosis. Hyperkyphosis is serious. That's gibbous deformity where you really, it's like hunchback. But I'm just talking about people with bad posture, with rounded shoulders and rounded upper back. So I get that a lot. People saying, you know, and it's a lot of the time it's aesthetic. People just don't want to be, they want to, you know, so we need to work in a certain way with that. But general back care, classes I would like to do eventually when lockdown is, I've kind of got plans for that. I'd like to be doing herniation workshops and general back care class, back care basics. So that's for someone who wants to keep their back healthy, give ourselves the best chance to have a healthy back going forward, not necessarily a problem, just healthy back care classes, and then general lower back pain, non-specific to herniation, scoliosis, just someone that goes, you know, my lower back gets sore, and specific classes. Because I know in the States they do, and they're amazing at it, you know, where they've got 14, 20 people in one class, all with scoliosis, but with different curves. It's incredible. That just, they do have assistants, so they have one teacher and they have 2 assistants. Because what I'm telling Emma and Ashton to do is the exact opposite to what Juliet and Taryn must do, because the curves are different. So when you start doing group classes, it gets quite tricky, but yes, I would love to eventually. Okay, anybody else? Any other hands? Chat, let's have a look. Sorry, I have to go. Okay, from the date. Okay, guys, anything else to add or question there? No. Okay, so this afternoon I did say, for those of you who might have missed it, a chair, and it doesn't have to be a yoga chair, just something that you can put your legs up on, a strap, yoga strap, 2 blocks, and a blanket. And then we'll have a look at general back care poses, traction poses that you can use for your students, and a lot that you could do in a general class, just for good, healthy back. Okay, I will see you at 1 o'clock. Okay, thank you. See you later.
Thanks,
Bye.
Bye.
Thank you. Bye.
Thank you.
Bye.
Bye.